Bismillahirrahmanirrahim. Uh, as the subtitle of my talk suggests, I would like to uh, make you apprise you of the fact that hypersensitivity pneumonitis is one of those fibrosing interstitial lung diseases which can be prevented. So, what is hypersensitivity pneumonitis? It is an interstitial lung disease resulting from the inhalation of an antigen to which the subject has been previously sensitized. It is typically triggered by exposure to specific, be they microbial, plant, or more commonly in our ecosystem, the avian exposures, inorganic chemical agents, and their byproducts. But there is an increasing evidence that although HP is caused by specific antigens, a trigger factor may be needed to induce the disease. Usually, most exposed individuals develop an immune tolerance, what is called an immune tolerance, whereby the antigen inhalation may result at most in a mild increase of local lymphocytes without clinical consequences. But the coexistence of genetic or environmental promoting factors provokes the development of an exaggerated immune reaction that results in marked lung inflammation. The right side of the slide depicts the quote unquote normal response where the immune tolerance lets it go. But on the other side, where genetic environmental promoting factors come into play, the story is different. A massive influx of immune cells, lymphocytes, and plasma cells, macrophages, contributing to a massive inflammatory response. And then there is inflammation of the alveolar walls because of this immune cell infiltration. And it is a granulomatous inflammation in HP. So we have clumps of immune cells and debris, tissue debris. Then around the alveoli, the interstitium is also involved, and the interstitial infiltration, the interstitial inflammation in the course of time may lead to fibrosis and scarring. So, how do we go about solving the diagnostic dilemma? A thorough exposure and clinical history is really mandatory. It is very important. You can have local questionnaires, adapt local questionnaires. The serum IgE testing against potential antigens, the HRCT scan, multidisciplinary discussion, and BAL lymphocytosis, or further on, other semi-invasive procedures. And this is the long list of antigen exposures. Therefore, the importance of a thorough history. Some of the common antigens that we come across, you all know about them, a smaller list, but some of them are more important than others. What we have had in our registry is that HP was overwhelmingly avian exposed, and females living in Karachi, for example, in the apartments at a height where a lot of pigeons make their abode, these housewives had a greater incidence of HP and even fibrosing HP, rather. Specific antibodies analysis can be useful as supportive evidence, but the lack of predictive values cannot differentiate between sensitization and disease. The selection of antigens to be tested often need to be determined locally according to the prevalent antigens. We are at a handicap because of the lack of availability of serum precipitins to identify the inciting agents. Coming to HRCT, the HRCT being the linchpin of all interstitial disease diagnosis, and more so for HP. You see here a CT scan of subacute HP, ground glass opacities or poorly defined small nodules are commonly found at this stage. In addition, a mosaic perfusion is observed in patients with extensive bronchoalveolar obstruction. And this is the classic HP specific, what is known as 3-density HRCT. It has a patchwork of normal density lung lobules in a mesh of ground glass densities, causing a mosaic attenuation. And the third is air trapping. Please look at this CT picture intently and internalize it. It's classic of hypersensitivity pneumonitis. Coming to chronic HP, the HRCT now becomes a combination of reticular, ground glass, centrilobular, nodular opacities associated with the usual signs of fibrosis, with interlobular septal thickenings, lobar volume loss, traction bronchiectasis, and honeycombing. At this point, the HP has irreversible architectural distortion, and it simulates the UIP types, and it is often difficult to differentiate. Initially, as we worked on, there was a lot of cases identified as IPF, but later on in our statistics, Ali will tell us that HP has been rising all over. So it is probably a better identification of the fibrotic changes between HP and UIP and IPF. Then comes the multidisciplinary discussion at this point, where there is ambiguity we need to discuss. And before going into any semi-invasive or invasive procedures, there's a little difference between what the ATS guidelines say. The ATS guidelines bring the multidisciplinary discussion a little later, but ACCP and others, and I think personally I would say at this point we should have a multidisciplinary discussion before we go into invasive diagnostic procedures. Bronchoscopic lavage searching for lymphocytosis, which should at least be more than 30% to be consistent with HP. The more the fibrosis, the lesser is this percentage. But again, this is not necessary where there is a definite exposure history, where there is strong clinical context, and the HRCT is typical for HP. Clinical presentations of HP have classically been defined as acute, subacute, and chronic. But recently, the classification has been simplified to non-fibrotic HP, which is purely inflammatory, and fibrotic HP, which may be a mixture of inflammatory and fibrotic, or purely fibrotic. Acute HP is basically characterized by an influenza-like syndrome that occurs after substantial exposure. The symptoms may gradually decrease over hours and days, but often recur with a re-exposure. In subacute HP, there is an insidious onset of symptoms, dyspnea, fatigue, and cough developing over weeks to a few months. Symptoms of become progressive and become more persistent. So that unrecognized and untreated subacute disease may evolve to chronic HP, characterized by progressive dyspnea, cough, fatigue, malaise, and weight loss. This presentation is most commonly seen in patients with bird antigen exposure, where the source of exposure has not been removed. In management, prevention is a very important measure. In high-risk environments, education and awareness should be given as much as possible. Improvements in work conditions and reduction in the occupational exposure. Preventive measures like masking, proper ventilation, but most importantly, minimize the microbial or avian antigen exposure by having a clean environment at home and strict avoidance of avian pets. At this point, lung functions have a role, not that they distinguish between other types of ILD. No, they do not. They have the same physiological profile of restricted pattern with low diffusion. But the importance of pulmonary function is to determine the severity of the physiologic impairment at the time of diagnosis. In our data registry, HP had the worst FVC at the time of diagnosis. It is something like the median FVC has been 46.5% of the predicted, which is even worse than the FVCs in IPF. So they're determining the severity. And then when we are using corticosteroids, the question is there a role for the steroids and for how long and until when? The PFTs can help us in this. Again, when we are prescribing antifibrotic drugs, it is necessary to follow up these antifibrotic drugs periodically and see whether they are doing any good and stalling the decline of the FVC. This could only be done without any risk of radiation. As Salim rightly pointed out, HRCTs would only be needed once a year or if there is an immediate need. Early diagnosis, identification, and elimination of the inciting antigen is extremely important. We often see that treatment is started and the results are not right. But when you inquire, you reach to the conclusion that the incriminating agent, the inciting agent, has not been removed for various social reasons. It is important to make them realize that despite the social whatever limitations, this has to be done. There is no established algorithm for the pharmacologic treatment of HP. Corticosteroids do hasten the recovery from the acute stage, but again, when fibrosis has set in, then the use may be debatable or not of much use. The dose is, the usual is 0.5 to 1 milligram a kg a day, starting with 40 to 60 milligrams for 4 to 6 weeks, and then tapering down to a minimal 10 milligrams maintenance in non-fibrosing HP. But again, in a pure fibrosis, this may not work. The other drugs used like icofenolate and azathioprine with or without prednisolone, these are varied results. Again, rituximab, there was one trial, but again, nothing worthwhile. In antifibrotic, the inbuilt trial for nintedanib and the relief for pirfenidone do set a criterion of decline being contained over 1 year. The factors associated with mortality in patients with HP, most of them have been done. Yeah. Most of them have been done already, but old age, male gender, non-identification of the inciting agent or non-removal of the inciting agent from the exposure, and then bad FVC to start with, and rapid decline of FVC, low lymphocytes in the bowel fluid, all these, and UIP on the HRCT, all these are adverse factors as far as the prognosis is concerned. In general, patients with acute disease, if correctly and timely diagnosed and treated, have a good prognosis. By contrast, patients with subacute chronic HP, in particular, those with avian exposure, often progress to irreversible pulmonary fibrosis. Pulmonary hypertension was, again, one thing that came out clearly in our data. And like 20% is probably an international figure, but we have had about more than 40% of pulmonary hypertension with HP in our cases, and about 18% of them were severe pulmonary hypertension with a pulmonary artery pressure greater than 55 millimeter mercury. With that, I come to the end. This has been a short, brief presentation. Thank you very much.